Hello everyone, I'm Dr. Jyoti, working as an advanced physiotherapist at Lifeshots Healthcare Center, where we focus on evidence-based and advanced rehabilitation program for musculoskeletal and sports injury. Today, I will be presenting a case of a 16-year-old male competitive football player who developed persistent ankle pain and instability after a sports injury. Before we go into the case, let me ask everyone something. Which joint is most commonly injured in sports injury? Comment down your answers. Yes, you are absolutely right. The answer is ankle joint. While I present the case, try to identify which ligament is most likely injured. Our patient is a 16-year-old male competitive football player who presented with pain in the left ankle, swelling, stiffness, and a feeling of instability while walking and running. He also reported difficulty with activities like stair climbing, running, and returning to football. Now we will discuss mechanism of injury. The injury occurred on 13th October 2025 during a football match. Now I want to ask you a question. In football, what is the most common mechanism of ankle sprain? Most ankle sprain occurs due to inversion of the ankle while the foot is in plantar flexion. This position places maximum stress on the anterior talofibular ligament, which is the weakest ligament of the lateral ankle complex. After the injury, the patient was treated with plaster of Paris immobilization for 1.5 months and was allowed partial weight bearing. However, after removal of the cast, the patient continued to experience persistent swelling, pain during weight bearing, and instability. Why do you think the patient sometimes develop chronic ankle problem even after immobilization? The answer is joint stiffness, muscle weakness, lack of proprioceptive training, incomplete ligament healing. The patient reported pain over the anterolateral region of the ankle. We have taken pain score using NPRS scale, which was 9 out of 10 during weight bearing and 7 out of 10 during non-weight bearing activity. On observation, there was visible swelling around the ankle. Circumferential measurement shows and half a centimeter more swelling on the left ankle compared to the right side. Now, let me ask you something. Why is it important to compare the swelling with the opposite side? Because it gives us a baseline for normal anatomy and help quantify the extent of edema. Now we will talk about posture of the patient. In standing, the patient maintained mid-plantar flexion, slight inversion, decreased weight bearing on the affected side, and in sitting, the ankle rested in slight plantar flexion with protective guarding. And in supine, the limb showed a subtle equinus posture with external rotation likely to reduce stress on the lateral ligament. On palpation, we observed tenderness was present over the ATFL. Local temperature was slightly increased as compared to the unaffected side. Non-pitting edema was present. On examination of range of motion, dorsiflexion and eversion was restricted. Manual muscle testing revealed grade 3 plus strength in the ankle musculature. To assess ligament integrity, several special tests was performed. Anterior draw test and talar tilt test was positive, and the squeeze test for ankle was negative. The squeeze test was performed to rule out syndesmotic or high ankle sprain. Balance assessment showed several impairments. The patient could maintain single leg stance for less than 2 seconds. Dynamic balance tests, such as star excursion test, could not be performed due to pain and instability. Why does proprioception decreases after ligament injury? Because ligament contain mechanoreceptor responsible for joint position and sense. Gait assessment revealed an antalgic gait pattern with reduced Push off, early heel raise, lateral loading of the foot, decrease stance time. To measure and identify foot pressure and ankle instability, we have used plantar pressure analysis device. Here we perform the plantar pressure analysis during a squat test. This system measures pressure distribution, center of pressure movement, and medial lateral stability. In this patient, the maximum medial lateral deviation was 88.21 mm, which means the pressure shifted excessively from side to side. In a stable ankle, the center of pressure should remain relatively controlled during a squat. However, this patient shows increased lateral shift, suggesting subtalar instability and poor neuromuscular control, likely due to injury of anterior talofibular ligament. The pressure map also shows increased loading on specific areas of the foot, indicating compensatory weight distribution. Now we have taken affected left single stance test. This test evaluates static balance and proprioception. The patient stands on one leg while the system measures how much the center of pressure moves. The key findings here include sway distance of 587 mm, velocity sway of 46 mm per second, and anterior posterior deviation of 60.64 mm. Higher sway values indicate poor postural stability. In a healthy ankle, the center of pressure should remain relatively stable. However, in this patient, we see excessive sway which suggests a proprioceptive deficit. This occurs because the anterior talofibular ligament contains mechanoreceptors responsible for joint position sense. When the ligament is injured, proprioceptive feedback decreases, resulting in reduced balance control. At the end, we have taken left leg hop test analysis. This test evaluates dynamic stability and landing control, which are essential for athletes returning to sports. During the hop test, the patient jumps and lands on the affected leg while plantar pressure sensors analyzes landing mechanics. Findings include total pressure of 17,954 kilopascal, sway velocity of 223 mm per second, and anterior posterior deviation of 300. The key observation is fragmented contact during landing. This means the foot did not land smoothly and instead showed multiple unstable pressure points. This suggests poor shock absorption, impaired neuromuscular control, instability during dynamic movement. Such finding indicates the patient is not yet ready for high level sports activity. Now, we have clinically diagnosed based on inversion injury mechanism, tenderness over the ATFL, positive anterior draw test, positive talar tilt test, and functional instability. The case is consistent with chronic grade 2 injury of the anterior talofibular ligament. An important concept to remember is that ligament injury not only affects mechanical stability but also neuromuscular control. If rehabilitation does not include proprioception and balance training, the patient may develop chronic ankle instability.